Cerebrovascular diseases, diseases of the brain vessels including stroke and transient ischemic attacks. Stroke, brain attack, acute injury to the brain due to vascular problem, producing neurological deficits, acute in onset and persistent for more than 24 hours. Etiology, we have ischemic and hemorrhagic strokes. Ischemic stroke, the most common cause, 85% of the cases, occlusion of a blood vessel to a part of the brain leading to ischemia. Thrombosis leads to acute occlusion. Embolism leads to sudden occlusion. Hemorrhagic stroke, less common cause, 15% of the cases, rupture of a blood vessel in a part of the brain leading to bleeding. Thrombosis, clot in situ resulting in cerebral infarction. Burkow's triad, vessel wall disease, hypercoagulability or slow circulation. Vessel wall disease, cerebral atherosclerosis, the most common cause, or vasculitis, polyarthritis nodosa and SLE. Hypercoagulability due to polythalassemia, leukemia and thrombocytosis. Slow circulation due to heart failure or systemic hypoperfusion from dehydration or shock. Lacunar infarcts is the most common type of stroke. Sickle cell disease can also cause ischemic stroke. Embolism, wandering clot resulting in cerebral infarction. The source of embolus may be from heart, distal vessels or others. Heart, mitral stenosis with atrial fibrillation, vegetations of subacute bacterial endocarditis, or Murus thrombus in acute myocardial infarction. Distal vessels, arterial and venous. Arterial, detached atheromatous plaque from carotid vessels. Venous, DVT, detached thrombus, paradoxical embolism through VSD or ASD. Others, unusual, very rare, such as fat emboli, air emboli, parasitic emboli, and malignant cell emboli. Hemorrhage. Types of intracranial hemorrhage, we have intracerebral, subarachnoid, and subdural or extradural. Subarachnoid, bleeding in a subarachnoid space, subdural or extradural, bleeding causing hematoma. Intracerebral hemorrhage, the bleeding is in the brain substance leaking to the ventricles, so it's a very serious condition because the blood may compress vital centers. The commonest artery causing intracerebral hemorrhage is the lenticular striate branch of the middle cerebral artery. Causes of intracranial hemorrhage, hypertension. This is the commonest cause of intracerebral hemorrhage. Rupture of intracranial aneurysm, the commonest cause of subarachnoid hemorrhage. Head trauma, the commonest cause of subdural hematoma and subarachnoid hemorrhage. Hemorrhagic blood diseases, purpura and hemophilia. And finally, anticoagulants. So the most common causes of subarachnoid hemorrhage are head trauma and rupture of intracranial aneurysm. And then we have risk factors for stroke and transient ischemic attacks, non-modifiable and modifiable. Non-modifiable risk factors, old age, more in males than females with ratio 3:1, type A personality, and genetic factors, positive family history. Modifiable risk factors include high risk and less risk. High risk, heart diseases, especially valvular heart diseases and atrial fibrillation, hyperlipidemia, increased total cholesterol, increased LDL and decreased HDL, hypertension causing endothelial damage, diabetes mellitus and cigarette smoking. Less risk, obesity, diet rich in saturated fat and cholesterol, physical inactivity, psychological stress, hyperuricemia, homocystinemia, heavy alcohol intake, and CCPs. Clinical picture. Neurological deficits commonly produced depend on the affected brain area, such as hemiplegia, hemianesthesia, speech problems as aphasia and dysarthria, vision problems, field defects, ataxia, lack of coordination and lack of balance, cranial nerve paralysis. Clinical types: stroke in evolution or progressing stroke, enlarging brain infarct with neurological deficits that worsen over 24 to 48 hours, completed stroke or non-progressing stroke, stable brain infarct with neurological deficits that don't worsen with time. Investigations: brain imaging, other imaging, and laboratory tests. Laboratory tests: CBC, PT, APTT, risk factors, blood glucose, lipid profile, uric acid, homocysteine, hypercoagulability, protein C and S, and antithrombin 3 with KIFT and LIFT and TIFT. Other imaging: cardiac imaging, chest X-ray, ECG, echocardiography, vascular imaging, Doppler ultrasonic imaging. Brain imaging, we have CT and MRI. MRI, recent brain MRI protocols reliably diagnose both types of strokes. CT scan, image acquisition is faster with CT scanning more than MRI. CT is more available in emergencies than MRI, non-contrast CT scanning is the most commonly used form. CT also includes CT angiography and CT perfusion scanning. Ischemic stroke. Infarctions may not appear until 24 hours or more after onset. Small infarctions may not appear at all. Hemorrhagic stroke. Bleeding appears immediately even with very small lesions, so CT scan may help to rule out hemorrhagic stroke. Treatment. General care for hemiplegic patients or comatose patients in stroke unit. Skin. Frequent change in the patient's position every 2 hours and of the bed sheets. Frequent wash of the back and pressure points by alcohol followed by powder. Swallowing and nutrition, tube feeding and IV fluids. Balance of fluids, controlled IV fluids, breathing, suction of secretions and oxygen inhalation. Bladder, castration and urinary antiseptics. Bowel, daily enema. Symptomatic. Early and late. Early, cerebral dehydrating agents, mannitol to decrease brain edema, prophylaxis against stress ulcer. Late, we have physiotherapy. Specific treatment according to the type. For ischemic stroke, we have limitation of the infarct size, blood pressure control, neuroprotective agents, antiplatelets, anticoagulants, and treatment of the cause. Treatment of the cause includes thrombotic stroke, proper control of risk factors of atherosclerosis, embolic stroke, treatment of the source of emboli. Anticoagulants, they are indicated in stroke in evolution, recurrent transient ischemic attacks, embolic hemiplegia, especially in cardiac cases, to prevent recurrent embolization. Contraindications, hemorrhagic infarction, it's excluded by using CT scan, hemorrhagic blood diseases, hepatic and renal failure, and finally subacute bacterial endocarditis. Antiplatelets, aspirin, dipyridamole, ticlopidine, clopidogrel. Aspirin 75 to 300 mg per day single dose, clopidogrel 75 mg once daily. Then we have neuroprotective agents. Rationale, reducing the release of excitatory neurotransmitters by neurons in the ischemic penumbra may enhance the survival of these neurons, but limitations. Despite very promising results in animal studies, no single neuroprotective agent in ischemic stroke has yet been supported by human studies. Medications used, prevention of early ischemic injury and prevention of reperfusion injury. Prevention of early ischemic injury, NAMDA receptor antagonist, NAMDA stands for N-methyl D-aspartate, such as dextrofan. Side effects, hallucinations and agitation. Prevention of reperfusion injury, the good outcome generally associated with reopening of the blood vessels. Additional brain injury may result when reperfusion occurs because YBCs may lead to obstructing small vessels, leading to additional ischemia, and leukocytes also release toxic products that can lead to free radical formation. So we give enlimumab, monoclonal antibody, which blocks intracellular adhesion molecule ICAM on the endothelium to prevent adhesion of YBCs to the vessel wall. Then we have blood pressure control, hypertension control in non-tissue plasminogen candidates, and hypertension control in tissue plasminogen candidates. For non-tissue plasminogen candidates, if the blood pressure is less than 220 over 120 mm mercury in absence of total organ damage, blood pressure should be monitored and symptoms should be treated. Nothing more than this. But if blood pressure exceeds 220 over 120 mm mercury, we give labetalol, nicardipine, and nitroprusside. Labetalol is the initial drug of choice. Dosage 10 to 20 mg IV for 1 to 2 minutes. The dose may be repeated or doubled every 10 minutes to maximum dosage of 300 mg. Nicardipine alternative given IV at initial rate of 5 mg per hour, titrated by increasing the infusion rate 2.5 mg per hour every 5 minutes to maximum of 15 mg per hour. Nitroprusside may be used in severe cases, blood pressure exceeding 230 over 140 mm mercury at 0.5 mcg per kilogram per minute IV. The target blood pressure reduction is of 10 to 15%. Hypertension control in tissue plasminogen activator candidates. When blood pressure is less than 185 over 110 mm mercury, blood pressure is just monitored and symptoms should be treated if they appear. And if blood pressure exceeds 185 over 110 mm mercury, Blood pressure should be reduced and continuously monitored, and it's reduced by using the same 3 drugs, labetalol or narcoleptin or nitroprusside, given before and after the tissue plasminogen activator. Target blood pressure reduction is of 15 to 25%. Then we have limitation of infarct size. In case of thrombotic stroke, there are 3 brain areas of particular concern: central portion of the ischemic area permanently damaged, and the immediately surrounding area, it's called penumbra. It may be saved by appropriate and rapid treatment. And finally, we have the healthy area outside the penumbra. For this type of stroke, there are 2 treatment options to limit the infarct size. We have medical revascularization and mechanical revascularization. Medical revascularization using fibrinolytic therapy by IV recombinant tissue plasminogen activator. Duration: infusion within 3 to 4.5 hours after the onset of symptoms. Contraindications: bleeding with platelet count less than 100,000 per millimeter square, coagulopathy, local increased intracranial hypertension, severe hypertension more than 185 over 110 millimeter mercury unless a drug such as IV labetalol was successfully given and reduced the blood pressure below this range, severe hypoglycemia or hyperglycemia, whether less than 50 or more than 400 milligram per deciliter, rapidly improving symptoms suggestive of transient ischemic attack, relative contraindication, and finally advanced age older than 75 years, relative contraindication, and finally mechanical revascularization or thrombectomy, endovascular therapy. Recent alternative: when fibrinolytic therapy is ineffective or contraindicated, we use the stent retriever system. And then we are gonna discuss transient ischemic attacks. Mini stroke: sudden attacks of temporary cerebral ischemia too short to cause infarction. Duration: few minutes to hours, maximum 24 hours, followed by complete recovery. Value: warning for an approaching ischemic stroke. If the attack lasts for more than 24 hours, then the patient recovers. It's called RIND, R-I-N-D, reversible ischemic neurological deficit. Etiology: temporary reduction or cessation of cerebral blood flow in a specific neurovascular distribution can be due to acute thromboembolic event or low flow through partially occluded vessel. Most commonly, ulcerated atherosclerotic plaques in carotid or vertebral arteries, or thrombi in diseased hearts such as atrial fibrillation. Less commonly, vasculitis from SLE or PAN, hyperviscosity from polycythemia. Clinical picture: we have carotid and vertebrovascular TIAs that we're gonna explain later. Prognosis: TIAs are warning signs for approaching ischemic stroke. If the time period of blood supply impairment lasts for more than few minutes, nerve cells of that area die, leading to permanent neurological deficit. 1/3 of the patients develop stroke. Risk of developing stroke is striated according to the ABCD Power 2 score. A for age more than or equal 60 years means 1 point. Blood pressure more than or equal 140 over 90 millimeter mercury, 1 point. Clinical features: unilateral weakness, 2 points. Speech disturbance without weakness, 1 point. D, duration of the attack more than or equal 60 minutes, 2 points. From 10 to 59 minutes, 1 point. And another D, diabetes, 1 point. Interpretation of the score: score from 1 to 3 points, low risk, 4 to 5, moderate, and more than 6 or equal to 6, high. Then we have investigations: brain imaging, CT scan to rule out intracranial hemorrhage, other imaging, cardiac imaging, chest x-ray, ECG, echo, vascular imaging, MRA, CTA, Doppler ultrasonic imaging, laboratory tests, CBC, PT, APTT, blood glucose, lipid profile, uric acid, homocysteine, hypercoagulability, protein C and S, and antithrombin 3. Treatment: we have medical treatment, surgical treatment. Medical treatment: antiplatelets for non-cardioembolic TIAs, aspirin 75 to 300 milligram per day, or clopidogrel 75 milligram once daily, and we can add dipyridamole or ticlopidine. Anticoagulants for cardioembolic transient ischemic attacks, warfarin, target INR from 2 to 3. Treatment of risk factors: proper control of hypertension. Surgical treatment: End arterectomy in carotid artery stenosis more than 70%. The technique, incision is made to open the artery, the plaques are removed and the artery is closed. This preventive surgery clears carotid arteries of fatty deposits or atherosclerotic plaques before another TIA or stroke to occur. Surgical bypass between the MCA, middle cerebral artery, and ECA, external carotid artery, and it's generally not beneficial. Carotid angioplasty and stent technique, angioplasty balloon to dilate the stenotic artery, stent, intraluminal stent to maintain patency of the dilated artery. Value: it maintains patency of the carotid circulation and offer benefits to over the surgical procedures. Blood supply of the brain. The blood reaches the brain through two systems of blood vessels, carotid system and vertebrobasilar system. Carotid system, internal carotid artery. Each carotid artery enters the cranial cavity through carotid foramen and canal to the cavernous sinus, lying lateral to the optic chiasma. During its passage through the cavernous sinus, it gives three small branches of thalamic artery, anterior choroidal artery, and posterior communicating artery. The artery finally divides into two main internal branches, anterior cerebral and middle cerebral arteries. Internal carotid artery occlusion. Etiology: most commonly atherosclerosis of the artery from 4 to 6 decades and most commonly affecting males. Clinical picture: we have recurrent carotid transient ischemic attack and stroke, complete carotid occlusion. Transient ischemic attacks lead to transient sudden headache, transient convulsions, transient ipsilateral blindness, transient contralateral hemiparesis and hemihypothesia, transient aphasia in lesions of the dominant hemisphere. Then we have stroke or complete carotid occlusion, and it may be preceded by TIA. It leads to ipsilateral blindness, contralateral hemiplegia and hemihypothesia, aphasia in the lesions of dominant hemisphere, and finally contralateral homonymous hemianopia. Middle cerebral artery: it runs on the lateral surface of the cerebral hemisphere, supplying the lateral aspect of the anterior 3/5 of the cerebral hemisphere, giving capsular branch and cortical branch. Capsular branch or reticulostriate artery supplying all dorsal half of the internal capsule. Capsular branch occlusion: most commonly occluded artery leading to contralateral complete hemiplegia affecting upper and lower limbs to the same extent. Contralateral upper motor neuron lesion of the facial and hypoglossal nerves. Contralateral hemihypothesia, contralateral hemianopia may occur, but no convulsions, no aphasia, no coma. Cortical branches: frontal branch, motor area of face, upper limb, speech area 44, and motor writing area 45. So its occlusion will lead to contralateral faciobrachial monoplasia, motor aphasia, and agraphia. Motor aphasia and agraphia in lesions of dominant hemisphere. Parietal branch supplies sensory area of upper limb, angular gyrus area 39, supramarginal gyrus area 37, upper fibers of optic radiation. Parietal branch occlusion will lead to cortical sensory loss of the upper limb, alexia in lesions of dominant hemisphere, apraxia of both sides in lesions of dominant hemisphere with contralateral lower quadrantic homohemianopia. Temporal branch supplies auditory areas and lower fibers of the optic radiation, so its occlusion will lead to auditory agnosia in lesions of dominant hemisphere and contralateral upper quadrantic homohemianopia. So if we're gonna sum up and discuss the occlusion of cortical branches, which is more important than the anatomy: frontal branch, motor aphasia and agraphia in the dominant hemisphere lesions with contralateral faciobrachial monoplasia. Parietal branch, alexia, apraxia of both sides in lesions of dominant hemisphere with cortical sensory loss of upper limb and contralateral lower quadrantic homohemianopia. Temporal branch occlusion, auditory agnosia in lesions of dominant hemisphere with contralateral upper quadrantic homohemianopia. Main artery occlusion, coma and convulsions at the onset because lesion is extensive. Contralateral hemiplegia affecting upper limb more than lower limb. Contralateral hemihypothesia with more cortical sensory loss in the upper limb. Contralateral homonymous hemianopia. And finally, aphasia, motor aphasia, agraphia, alexia, auditory agnosia, and apraxia in lesions of dominant hemisphere. Then we have the anterior cerebral artery. It runs on the medial surface of the cerebral hemisphere, supplying the medial aspect of the anterior 3/5 of the cerebral hemisphere, giving capsular and cortical branches. Capsular branch, or Hübner's artery, supplying the ventral half of the anterior limb of the internal capsule. Its occlusion leads to contralateral faciobrachial monoplasia, proximal more than distal. Cortical branches, we have frontal branch, supplying the prefrontal area responsible for mentality, personality, and inhibition of primitive reflexes. So its occlusion leads to mentality changes, personality changes, and positive grasp reflex. Paracentral branch supplies motor area of lower limb, sensory area of lower limb, and paracentral lobule. So its occlusion leads to contralateral monoplasia and contralateral cortical sensory loss in the lower limbs, with incontinence of urine in bilateral region of the paracentral lobule. Callosal branch, supplying corpus callosum, leads to apraxia of the same side of the dominant hemisphere. So, main artery occlusion leads to contralateral hemiplegia affecting lower limb more than upper limb, contralateral cortical sensory loss in the lower limb, mentality and personality changes with positive grasp reflex, incontinence of urine in bilateral regions, and apraxia of the same side of the dominant hemisphere. If we're going to compare between the anterior cerebral artery injury and middle cerebral artery injury or occlusion, the anterior cerebral artery affects the lower limb more than the upper limb, while the middle cerebral artery affects upper limb more than the lower limb, whether in the hemiplegia or the cortical sensory loss. And we're going to add the prefrontal area in the anterior cerebral artery, while we're going to add the hemihypothesia and homonymous hemianopia in the middle cerebral artery. Internal capsule, broad band of white fibers lying in the depth of the cerebral hemisphere, formed of anterior limb, posterior limb, and genu. Anterior limb between caudate nucleus and lentiform nucleus, posterior limb between thalamus and lentiform nucleus. Blood supply, the ventral half of anterior limb supplied by the capsular branch of anterior cerebral artery, Hübner's artery. The ventral half of knee and posterior limb supplied by the capsular branches of the posterior cerebral artery, thalamo-genticulate artery, while the dorsal half of the anterior limb, knee, and posterior limb of the internal capsule is supplied by the capsular branch of the middle cerebral artery, reticulostriate artery. Fibers passing through the internal capsule. Sensory fibers from thalamus ascend in the posterior limb. Auditory and optic radiations pass in the posterior part of the posterior limb. Associative fibers pass in the anterior part of the anterior limb. And finally, pyramidal fibers descend in the genu, adjacent part of the anterior limb, and anterior half of the posterior limb. Fibers supplying the arm, followed by supplying the head, trunk, and finally the lower limb. Then we have the vertebro-basilar system. Each vertebral artery passes upwards through the vertebral foramina to intercranial cavity through foramen magnum, running upwards on each side of the medulla. Both vertebral arteries meet at the lower border of the pons to form one midline artery called basilar artery. The basilar artery runs upwards on the ventral surface of the pons, giving small branches known as paramedian arteries to the brainstem. Then it divides to two terminal branches called posterior cerebral arteries. Each posterior cerebral artery supplies the following loops: whole occipital loop and posterior part of the temporal loop, posterior 2/5 of the cerebral hemisphere. Each posterior cerebral artery gives the following branches: posterior communicating artery, cortical branches to the posterior 2/5 of the cerebral hemisphere, and capsular branch supplying the ventral half of the posterior limb of the internal capsule, the thalamus, and the genticulate bodies, called thalamo-genticulate artery. In its course, the vertebro-basilar system gives the following branches: two spinal arteries combine to form anterior spinal artery, and three cerebellar arteries on each side, superior, middle, and inferior cerebellar arteries. Circle of Willis formation anteriorly by the union of both anterior cerebral arteries through anterior communicating artery, and posteriorly by the union of each posterior cerebral artery by the internal carotid artery of the same side by posterior communicating artery. Therefore, in circle of Willis, the two carotid arteries communicate with each other and with the vertebro-basilar system. It's present in the subarachnoid space at the base of the brain. Relations: anteriorly, olfactory tract, optic chiasma; middle, cavernous sinus, optic chiasma, posterior, midbrain, and oculomotor nerve. Vertebrobasilar system occlusion, vertebrobasilar artery, the main vessel occlusion. We have recurrent TIAs and stroke. Stroke, complete occlusion. We have deep coma, complete quadriplegia with decerebrate rigidity, bulbar paralysis, hypoventilation, leading to acute respiratory failure. So it's usually fatal, affecting respiration, deep coma, quadriplegia, and bulbar paralysis. Recurrent vertebrobasilar transient ischemic attacks, we have syncope, diplopia, ophthalmoplegia, vertigo, tinnitus, bulbar symptoms, dysphagia, dysarthria, nasal regurgitation, and hoarseness of voice, hemiparesis and hemianaphasia, ataxia, and these manifestations indicate insufficiency of the artery, which may terminate in complete occlusion of the artery. Then we have posterior inferior cerebellar artery. It arises as a branch of the vertebral artery, terminates to supply inferior part of the cerebellum. It runs upwards on the lateral aspect of the medulla, supplying its upper lateral part, which contains nuclei of the 9th, 10th, and 11th cranial nerves, sympathetic fibers of the eye and the face, spinal sensory nucleus of the 5th nerve for pain and temperature of the same side of the face, spinal lemniscus carrying pain and temperature for the opposite side of the body, and part of the vestibular nucleus with some of the reticular formation nuclei. So its occlusion will lead to ipsilateral Horner syndrome, ipsilateral cerebellar ataxia, nystagmus, dysarthria, incoordination, ipsilateral palatopharyngeal laryngeal paralysis, weakness of sternomastoid and trapezius, ipsilateral loss of pain, temperature sensations over the face, contralateral loss of pain, temperature sensations over the body, and finally acute onset associated with syncope, hiccup, vomiting, vertigo, and pain over the face. Brainstem branches occlusion, syndromes of brainstem hemiplegia, crossed hemiplegia. Posterior cerebral artery occlusion, capsular branch, thalamo-genticulate artery. It supplies the ventral half of posterior limb of the internal capsule. So its occlusion leads to lower limb monoplegia and thalamic syndrome. Thalamic syndrome includes thalamic pain, severe burning pain on the contralateral side, contralateral hemianesthesia with extrapyramidal manifestations due to ischemia of the basal ganglia. Cortical branch, supplying posterior 2/5 of the cerebral hemisphere. So its occlusion leads to visual agnosia in the dominant hemisphere and contralateral homonymous hemianopia plus preserved light reflex and preserved macular vision. Main artery occlusion, thalamic syndrome, visual agnosia, lower limb monoplegia, contralateral homonymous hemianopia plus preserved light reflex plus preserved macular vision. And this concludes our part for today.